Good afternoon, everyone. So, my next topic of the video, which I'm going to discuss with you, is on quinolones and fluoroquinolones. And before I start my video, I want to request you that if this video appears useful to you and if it is helpful to you, kindly subscribe to my YouTube channel, Dr. Nitika's Pharmacology Discussion. And now I'm going to discuss with you quinolones or fluoroquinolones. Now, what are quinolones? These are a family of potent synthetic broad spectrum antibiotics. Quinolones are the broad spectrum antibiotics or chemotherapeutic antibacterial agents. Now, first generation of the quinolones begins with the introduction of naltrexonic acid in 1962 for treatment of urinary tract infections and GI infections. Means first quinolone which was discovered was naltrexonic acid and it was used in the urinary tract infections and GI infections. Naltrexonic acid was discovered by George Lesher and co-workers in a distillate during an attempt of chloroquine synthesis. And then in the early 80s was the introduction of fluoroquinolones, which have the fluoride atom in their structure. It is a quinolone which has the fluoride atom in their structure, so they are known as fluoroquinolones. The effects are that the good points or advantages of fluoroquinolones are that they are having the expanded spectrum of activity. They are highly potent. There is slow development of the resistance in these antibiotics. They have better tissue penetration, good tolerability, and protective streptococcus and anaerobes are spared. Their side effects can be seen with these fluoroquinolones, like the first drug, which is the fluoroquinolone, that is parfloxacin. It is known to cause maximum phototoxicity and QT prolongation, which is it is having the maximum phototoxicity. Getafloxacin is the fluoroquinolone, which is known to cause dysglycemia. That is, it can cause uh, G for getafloxacin and G for glucose level changes. So it can cause hyperglycemia also, and it can cause hypoglycemia also. And tamafloxacin can cause immune hemolytic anemia. Trovafloxacin can cause hepatotoxicity. Grapafloxacin can cause cardiotoxicity, and plinafloxacin can cause phototoxicity. Mechanism of action is that they act on the DNA gyrase and topoisomerase 4 enzyme. For gram-positive bacteria like Staph aureus, topoisomerase 4 is the primary activity inhibited by the quinolones. Means in the gram-positive bacteria, the enzyme is the topoisomerase 4, which is inhibited, and thus the replication of the DNA is stopped and there is killing of the bacteria. DNA gyrase is a primary quinolone target in gram-negative microbes, and DNA gyrase is in the gram-negative microbes like E. coli. Individual strands of double helical DNA must be separated to permit DNA replication or transcription. Means DNA is a double coil structure, and the replication takes place only at the straight ends. And when there is when we have to increase the replication, when we have to do when the replication has to be done, there is more coiling of the DNA takes place, and it is the ends are straightened. And DNA gyrase is the enzyme which cuts the coiled ends, and it uncoils it. It produces a negative supercoiling in those strands, and then it makes the end straight. So means DNA gyrase, it increases the length of the replicated DNA. So it can be used for replication and transcription. Anything that separates the strands results in overbonding and excessive positive supercoiling of the DNA in front of the point of separation. Means which will separate the strands. There will be overbonding, supercoiling will be more, and we have to prevent it by the help of the DNA gyrase. It induces the negative supercoils into the DNA, so both strands can be cut to permit passage of the segment of DNA through the break. The break then is resealed. Now, it can be composed of two subunits, A subunit and B subunit. A subunit, it causes strand cutting function of the gyrase, and they are the site of action of the quinolones. Mutation of the gene that encodes the A subunit polypeptide can confer resistance to these drugs. Means if there is a mutation on the gene acting on the A subunit polypeptide, it can cause the resistance to these drugs. Topoisomerase 4 separates interlinked daughter DNA molecules that are the product of DNA replication. Eukaryotic cells contain type 2 DNA topoisomerase that removes the supercoils, positive supercoils from the DNA to prevent its tangling during replication. Quinolones inhibit eukaryotic type 2 topoisomerases only at high concentration. Now, this is the mechanism of action. This is the supercoiled DNA. This is supercoiled DNA, and these are the straight ends for the replication. And these DNA gyrase, it causes the negative supercoils, and it will make the ends straight, causes nicking, and then it causes the negative supercoils, and it will lead to replication of the DNA. Topoisomerase 4X here. And these fluoroquinolones, they bind to these DNA gyrase, and topoisomerase 4 inhibit the DNA replication. Now, resistance can be by the mutations in the bacterial chromosome genes encoding DNA and topoisomerase, or there can be efflux pumps like active transport of a drug out of the bacteria. There is no quinolone modifying or inactivating activities. Resistance has increased in Pseudomonas, Staphylococci, Salmonella, Neisseria gonorrhoeae, and Streptococcus pneumoniae. And this is the antibacterial spectrum of fluoroquinolones. It is effective against the E. coli, Salmonella, Shigella, Enterobacter, Campylobacter, Neisseria, Pseudomonas aeruginosa, and Staphylococci. It is basically active against the gram-negative plus gram-positive plus anaerobes plus atypical mycobacteria like mycoplasma. Activity in Streptococcus is limited to levofloxacin, getafloxacin, and moxifloxacin. Intercellular bacteria are inhibited by chlamydia, mycoplasma, legionella, brucella, and mycobacterium. Pharmacokinetics, these are well-absorbed orally drugs, and these are widely distributed in the tissues, body tissues. And these are obtained, serum levels can be obtained within 1 to 2 hours of an oral, 1 to 3 hours of an oral dose. And food doesn't impair the oral absorption, but may delay the time to reach the peak serum concentrations. Oral dose in adults, ofloxacin is 2 to 400 milligram every 12 hours. Norfloxacin is 400 milligram every 12 hours. Ciprofloxacin is 250 to 750 milligram every 12 hours. Volume of distribution is high in urine, kidney, lung, prostate tissue, stool, bile, macrophages, and neutrophils. Concentration in cerebrospinal fluid, bone, and breast milk are lower than in serum. And these quinolones, these are cleared predominantly by kidney, and in renal failure, the doses has to be reduced. And this safe in renal failure are the drugs which are the PMT, that is pfloxacin, moxifloxacin, and tovafloxacin. These are metabolized predominantly in the liver, and these are safe in the renal failure. And none of these agents, these are effective in the peritoneal dialysis or hemodialysis. And therapeutic uses, these can be used in the urinary tract infection, and the most common quinolone use is nalidixic acid. Fluoroquinolones are more potent, and they have a broader spectrum of activity. They are more efficacious than trimethoprim and sulfamethoxazole for the treatment of UTI. Prostatitis, norfloxacin, ciprofloxacin, ofloxacin are effective, and these are administered for 4 to 6 weeks, appears to be effective in patients not responding to trimethoprim and sulfamethoxazole. Sexually transmitted diseases like chlamydia, urethritis, or cervicitis, 7-day course of ofloxacin is an alternative to 7-day treatment with doxycycline or a single dose of azithromycin. Means in chlamydia, cervicitis, or urethritis, we can give 7-day course of ofloxacin. Gonococci, a single oral dose of fluoroquinolone like ofloxacin or ciprofloxacin is effective treatment for sensitive strains, but increasing resistance has led to the ceftriaxone being the first line agent for this. Means for the gonococci, the third generation cephalosporin ceftriaxone is effective, and we can also use ofloxacin and ciprofloxacin and single oral dose for effective treatment. Shankara, 3 days of ciprofloxacin is the treatment. GI and abdominal infections for traveler's diarrhea, which is caused by enterotoxigenic E. coli, quinolones are equal to trimethoprim and sulfamethoxazole in effectiveness, and the duration of stools they reduce by 1 to 3 days. Shigellosis, norfloxacin, ciprofloxacin, and ofloxacin given for 5 days. They are effective for the treatment of the patient with shigellosis. Yeah, with even shorter courses effective in many cases. The in vitro ability of the quinolones to induce Shiga toxin gene in E. coli suggests that the quinolones should not be used for Shiga toxin producing E. coli. Enteric fever, the ciprofloxacin and ofloxacin can be given, and these can be given, which are caused by Salmonella typhi, and as well as bacteremic non-typhoidal infections in AIDS patient, and it clears chronic fecal carriage. Peritonitis, ciprofloxacin and ofloxacin is effective in peritonitis in patients on chronic ambulatory peritoneal dialysis, likely owing to the higher minimum inhibitory concentrations for these drugs for the coagulase negative staphylococci that are a common cause of peritonitis in this setting. Respiratory tract infections, these are oh my god drugs like ofloxacin, moxifloxacin, and getifloxacin are effective, plus levofloxacin, which is LS isomer of ofloxacin. These are the drugs effective for the treatment of respiratory tract infections. So, the norfloxacin and ofloxacin and ciprofloxacin can act against Salmonella, Streptococcus pneumoniae, and anaerobic bacteria. And getifloxacin and moxifloxacin are effective against Streptococcus pneumoniae. Ciprofloxacin and levofloxacin is effective against Legionella hemophilia, and these are also eradicating the infection against Haemophilus influenzae or Xylella catarrhalis. These can be given in the patients with cystic fibrosis, and clinical data has demonstrated that a clear role for a newer fluoroquinolones are single agents for treatment of community-acquired pneumonia. Bone, joint, and soft tissue infections, treatment like osteomyelitis requires prolonged antimicrobial therapy with agents against Staphylococcus aureus and gram-negative rods. So doses 500 milligram to 750 milligram twice daily are recommended, and they may require treatment for 4 to 6 weeks. Doses should be reduced for patients with severely impaired renal function. Diabetic foot caused by gram-negative rods, anaerobe streptococci, staphylococci. Fluoroquinolones in combination with anti-anaerobic agents are the drug of choice. Other infections like prophylaxis of anthrax, ciprofloxacin is given. Tularemia, ciprofloxacin is given. And it can be given for the multi-drug resistant tuberculosis, quinolones, and for the treatment of atypical mycobacterium infections, like as well as mycobacterium avium complex infections in AIDS. Prophylaxis in neutropenic patients decreased the incidence of gram-negative rod bacteremias. Adverse effects will be GI infections like nausea, vomiting, abdominal discomfort. Ciprofloxacin is the most common cause of Clostridium difficile chloritis. Getifloxacin is known to cause the hypo or hyperglycemia in young older adults. G for getafloxacin, G for glucose levels. And skin and hypersensitivity reactions can cover phototoxicity, more seen by sparfloxacin. Serious cutaneous reactions can occur, pruritus, urticaria, CNS like hallucinations, delirium, and these are also seizure inducing. And they can be other predisposing factors are present or at high doses. Ciprofloxacin or p-floxacin inhibit the metabolism of theophylline. Means theophylline is the antiasthmatic drug, and they will inhibit the metabolism of theophylline. So levels of theophylline will increase in the body. So they will cause the toxicity from elevated concentrations of the theophylline, which is methylxanthine, may occur. No steroidal anti-inflammatory drugs may augment displacement of gamma aminobutyric acid from its receptors by the quinolones. Achilles tendon rupture can occur tendinitis in patients of more than 60 years old, patients taking corticosteroids in solid organ transplant recipients. Patients taking corticosteroids can be affected or in organ transplant recipients. Use of quinolones in children have been known to cause cartilage damage in weight-bearing joints. So these are contraindicated in children also. However, children with cystic fibrosis and multi-drug resistant typhoid given ciprofloxacin, norfloxacin, or nalidixic acid have had few and reversible joint symptoms. And ciprofloxacin should not be given to pregnant women. QT interval prolongation has been observed with sparfloxacin, and it is also known to cause the phototoxicity, and to a lesser extent with getafloxacin and moxifloxacin. And it should be used in caution with patients on the class 2 like class 3 like amidron, and class 1A like punitine procainamide antiarrhythmics. Generations. Researchers divided the quinolones into generations based on their antibacterial spectrum. Like the earlier generations, they are effective more against the gram-negative, and the third and fourth generation are effective more the anaerobes and gram-positive bacteria. They have a narrow spectrum of activity, the first generation, and the third and fourth and second generation have a broader spectrum activity. Like first generation, these are effective against gram-negative activity, and for the treatment of UTI, they're effective against gram-negative rods. These are second generation, these are effective against the gram-negative, plus they are effective against atypical organisms and gram-positive rods also, gram-positive cocci also, like Mycoplasma pneumoniae and Chlamydia pneumoniae. Third generation are effective against gram-negative rods and gram-positive cocci, and they are also effective against atypical organisms and Mycoplasma, Chlamydia. And fourth generation, these are this shows improved gram-positive coverage, mainly gram-negative activity, and against the anaerobic coverage. These are effective against the anaerobes also, and gram-positive cocci, gram-negative rods, gram-positive bacilli, these are effective. First generation are norfloxacin, ciprofloxacin, ofloxacin, p-floxacin. Second generation are levofloxacin, moxifloxacin. Third generation are moxifloxacin, gamifloxacin, and fourth generation are sparfloxacin and tulifloxacin. Norfloxacin, which is less potent, it is effective against the urinary tract infections and genital tract infections, commonly used for the treatment of chronic UTI. Not for respiratory and other systemic infections, methyl derivative p-floxacin, preferred for meningeal infections, longer half-life, reduced in liver disease. Ofloxacin is effective against gram-negative bacteria, and it also inhibits the Mycobacterium tuberculosis and Mycobacterium leprae. Inhibition of theophylline is less marked. Gonorrhea, single dose 200 to 400 milligram is effective. It is effective in the respiratory tract infections like chronic bronchitis and ENT infections. Levofloxacin, L-isomer of the ofloxacin, it is also effective against Streptococcus pneumoniae. Oral bioavailability is 100%. Theophylline, warfarin, cyclosporin, and zidovudine remain unchanged. Means these are not, they do not inhibit the metabolism of these drugs. Fulefloxacin, product of ulefloxacin, it is effective against gram-positive organisms and also the gram-negative organisms. Converted to ulefloxacin during first-pass metabolism rapidly, which is then excreted unchanged in urine. Use acute exacerbations of the chronic bronchitis UTI. Adverse effects not to prolonged QT interval. These are the uses, like these can be effective against the respiratory tract infections caused by Haemophilus influenzae, Legionella pneumophila, Pseudomonas aeruginosa, and the first line drug of the pneumonia, sinusitis, Streptococcus pneumoniae. Anthrax caused by Bacillus anthracis, ciprofloxacin is effective, and gonorrhea caused by Neisseria gonorrhoeae, ciprofloxacin is effective. GI infections caused by Enterobacter species like E. coli, Klebsiella, Proteus, Serratia, Shigella. The ciprofloxacin is effective in urinary tract infections caused by E. coli, Proteus, Klebsiella, Escherichia coli, Shigella. These are more effective than the sulfamethoxazole and trimethoprim combination. And this is used for complicated as well as uncomplicated UTI infections. Mechanism of action, I've already told you, these act by inhibiting the bacterial topoisomerase 2 and topoisomerase 4, that is DNA gyrase. They prevent the relaxation of positively supercoiled DNA that is required for normal transcription and replication. Inhibition of DNA gyrase will prevent the relaxation of the positively supercoiled DNA. Inhibition of topoisomerase 4 probably interferes with the separation of replicated chromosomal DNA into the respective daughter cells during cell division. And the gyrase, they have the two subunits like A and B. And A is can cut one double strands of DNA, and this is ATP sensitive reaction. The energy is provided by B subunits. Quinolone is an inhibitor of the A subunit. Action of gyrase is inhibited and DNA replication or transcription is blocked. Novobiosin is an inhibitor of B subunit of the DNA gyrase, so it's actively against the gram-positive bacteria. And quinolones and fluoroquinolones eradicate bacteria by interfering with DNA replication, shown to be toxic to eukaryotes. And recent evidence has shown eukaryotic topoisomerase 2 is also target for a variety of quinolone-based drugs. Thus far, most of the compounds that show high activity against eukaryotic type 2 enzyme contains aromatic substituents at their C7 positions. Quinolones can enter cells through porins, and therefore these are less often used to treat intercellular pathogens like Legionella, pneumophila, Mycoplasma pneumoniae, and for many gram-negative bacteria, DNA gyrase is the target, and for the gram-positive bacteria, topoisomerase 4 is the target. This is the mechanism of action of various drugs like DNA gyrase inhibitor is quinolones. DNA-dependent RNA polymerase is rifampicin, which is effective in tuberculosis. Protein synthesis inhibitors are like tetracycline and pectinomycin, which is the aminoglycoside group of drug, which act at the 50S ribosome is the erythromycin, chloramphenicol, clindamycin. Cell membrane inhibitors are polymyxins, periplasmic space or cell wall synthesis inhibitors are beta-lactamases, aminoglycoside. Polycases metabolism is inhibited by trimethoprim, sulfonamides. Cell wall synthesis inhibitors are penicillin, cephalosporins, monobactams, carbapenem, cycloserine, vancomycin. Now, resistance develops by point mutation in the quinolone and a change in permeability of the organism, that is efflux pumps and mutations in the quinolone binding region of the target enzyme. And it is primary target in the E. coli with single step mutants exhibiting amino acid substitution in the A subunit of gyrase, DNA gyrase. Topoisomerase is the 4 is the secondary target in E. coli that is altered in mutant expressing high levels of resistance. Resistance to quinolones in staphylococci and streptococci, the situation is reversed. Topoisomerase 4 is the primary target and gyrase is the secondary target. Resistance to one fluoroquinolone particularly is of high level, generally confers cause resistance to other members of this class. Means Staphylococcus and Streptococcus, the situation is reversed. Topoisomerase is the 4 is the primary target and gyrase is the secondary target. And resistance to one fluoroquinolone means resistance to other fluoroquinolones also. That is, cause resistance is present. Pharmacokinetics is these are orally given, absorbed, very well absorbed, and distributed well in fluids, tissues. Biotransformation is by the liver and eliminated by kidney, either tubular secretion or glomerular filtration. This is how the ciprofloxacin levels decrease with the milk and yogurt. This is the normal levels with water. This is with the milk. This is with the yogurt. How the effect of dietary calcium on absorption of ciprofloxacin takes place. Thank you. I hope you understood my video. And if you have understood the video, kindly subscribe to my YouTube channel. That is Dr. Nitika Hans Pharmacology Discussion. Thank you. Be happy, be healthy, be safe. Be happy. Thank you.